I'm Kenneth Cutbush. I'm a shoulder surgeon working in Brisbane. I'm going to take you through shoulder examination. Examining the shoulder is very important. We can tell a lot about what's going on with the shoulder with some very simple examination techniques, which I'm going to run through. So Violet, I'd like you to raise your arm up to the side for me like this, up overhead, all the way up, and then back down for me. Now take it up in front, and then back down. Tuck your elbows in, and then twist out for me with your thumbs up. Now up behind your back, just one at a time for me, and then this one for me. Now down by side. Just let me know if this causes you any grief. Does that worry you? What about that? No. From here, push your arm up into the air for me, please, up towards the ceiling. Pop your elbow down here for me, please. Hold there for me. Push against me. Okay, pop your wrist on your tummy. Pop your elbow forward. Now push my fingers onto your tummy. Good. From there, pop your arm out straight for me. Push up for me. Great. And does this worry you at all?
No.
What about this? Is that okay?
Yep.
From here, does that worry? Push up towards the ceiling? Is that okay?
Yeah.
And you're not tender here?
No.
So that's a very straightforward initial shoulder examination. I'm going to take you through it now. Really important to look at range of motion with the shoulder. The range of motion of the shoulder is a key part of the examination because it gives us great insight into shoulder function and to what's going on. So lift your arms up to the side. So here, someone with shoulder impingement or rotator cuff problems will get a catch at 90 degrees of abduction. So what we'll typically see is if I lift her arm up to this point, we'll get some pain. We'll see a grimace or a groan on the face. If that actually occurs, if we get that response a little bit higher up in the arc of abduction, so abduction is coming up to the side, that is more indicative of the AC joint rather than impingement of the rotator cuff on the undersurface of the acromion. Lifting up to the front gives us more information as well. So typically, impingement will be better coming up to the front because it's not as likely to catch on the undersurface of the acromion, whereas we will still get pain from the AC joint problem with that elevation, whether it's forward elevation or abduction. Next is external rotation. External rotation is a key feature in examining the shoulder. The important points are the elbows need to be on the ribs. When you first do this with people, everyone lifts their arm up like that, and that's not what we want to see. We want to see the external rotation, and for that we need the elbows tied in beside the ribs and actually look at the external rotation. First of all, we ask Violet to do the active range of motion, which we see there, and then we want to check the passive range of motion. So active is under motor control of the patient, passive is you actually doing it. And at this point, you will pick up frozen shoulder immediately because frozen shoulder is very clearly seen on the external rotation. And someone with frozen shoulder will typically have a very reduced range of motion in external rotation on the involved shoulder compared to the other side. So a typical thing would be someone getting to 70 degrees of external rotation on their normal side, and on the involved side, someone being 10 or 20 degrees, or if it's severe, they'll just get to 0 degrees. And you know immediately that patient has frozen shoulder and you have the diagnosis. There is only one other thing that causes significant loss of range of motion in the shoulder in general terms, and that's shoulder arthritis, and we can separate that out very quickly by asking to look at an x-ray. From there, we also want to know about internal rotation. Lift your arm up behind your back as high as you can go, and then the other side for me. Drop down, and just compare both sides. You want to know that it gives you more information about the shoulder. The next step is checking for impingement. So we do that in the scapular plane. The scapular plane is 30 degrees forward from the coronal plane, and we lift up to the side, and we're looking for a grimace or a groan at this point as it comes up, and you'll see it catch. Heads up, you have to be very careful with people. If someone has impingement, this can be extremely painful, and you want to be very gentle doing it. So often I'll ask, is this going to cause you pain if I lift up to the side? From there, we go into the Hawkins impingement sign, bend the elbow to 90 degrees, arm forward at 30 degrees, almost 90 degrees abduction, and we twist down like that. And usually with this, what I do is ask, if I do this, is this going to cause you pain? Because someone who has bad impingement, it's incredibly uncomfortable to do that to them. So that's shoulder impingement, and you will see that then. Shoulder impingement can be bursitis, tendonitis, rotator cuff tears. So it doesn't distinguish between a rotator cuff tear and just a tendinopathic shoulder or bursitis. The next thing is then to look at the rotator cuff itself. And what we're doing here is asking Violet to push up towards the ceiling. This is a static test, as opposed to impingement, which was a dynamic test. I'm actually moving the arm, so it's dynamic. This test is static. This arm stays still, and we ask her to push up against the ceiling. And what that does is tends to isolate the supraspinatus tendon and put it under tension. A bad tendon, a tendon that's unhappy, that has tendinitis or tendinopathic changes in it, will fire off pain signals doing that. So we know about the supraspinatus tendon and to a lesser extent the infraspinatus. Here at the side we'll get Violet to push back against me. This is isolating infraspinatus to a greater extent, and we're looking for weakness particularly, but also again tendinitis. Patients that don't have an infraspinatus tendon, they actually won't be able to twist out like that, and then if I put them there, they won't be able to hold it there. They'll actually drop in. We call that a lag, and that's indicative of no infraspinatus tendon. The next step is to examine the subscapularis. There are 3 tests for the subscapularis. My preferred initial screening test is this one, the belly press test, and you ask the patient to put their wrist, not their hand, the wrist on their tummy, and to bring their elbow forward, and then to push your fingers onto their tummy straight in. It's pushing in onto the tummy. What you want to see is the elbow can come forward. If the subscapularis is not working, or it's torn or deficient, what happens is, to do that, the patient will drop their arm back and then pull their hand back like that. So the elbow drops backwards so they can comply with the request to push the fingers onto the tummy. So that's subscapularis. The next test for subscapularis, Violet, I'd like you to put the palm of your hand up on the tip of your shoulder there for me, please. Now lift your forearm up parallel to the ground. That is often quite uncomfortable if they've got tendinitis to the upper part of the subscapularis. Now stop me pushing you up. Stop me. And then you put tension on it and load up the superior part of the subscapularis and see if they've got tendinitis in there. So that's the bear hug test. The belly press test, bear hug test. Now if you can turn to the side for me, please. 90 degrees. Pop your hand round behind your back. This is the Gerber lift-off test. Someone that has a big subscapularis tear will not be able to lift their hand straight back. Just push back against my finger, lift off the back of your hand. That's a normal test. An abnormal test, they just can't do that. And you can check from one side to the other side if you're not quite sure. So that was so that's testing the rotator cuff. Just turn back to the front for me, please. AC joint, the test for the AC joint, the first one is whether the AC joint's tender. The AC joint is this little lump just here at this point of the shoulder here. You can feel it just by gently rubbing your finger across, and you can feel the lump and push down on it. If that's tender, that suggests that the AC joint is a source of the pain, particularly if it has synovitis or arthrosis. From there, the test for the AC joint, crossbody adduction, is the type test for the AC joint. So you get to the elbow, have the arm straight, and push across the front of the shoulder, front of the body. That's quite uncomfortable with someone who has a sore AC joint. From there, you ask the patient to lift up towards the ceiling to push up. What that does is load the AC joint and twist it. If they've got an unhappy AC joint, that will fire off pain. And the next one is forced forward elevation, which is similar to what we saw with that arc of abduction test. That will be uncomfortable in a lot of people with AC joint problems. From there, I go to testing for instability. So I test the anterior apprehension test. So the arm is at 90 degrees and heads up. Someone who has a very unstable shoulder, you have to be very careful with this. You do it very gently and just watch them, and you don't take them past where they go. So with Violet, we'll take her up, arm to 90 degrees, elbow to 90 degrees, and then just twist back. And I've got my thumb on the back of the humeral head, and I'm pushing forward. And what you're looking for is actually a contraction of the muscles. We're looking for apprehension. So a positive test is the muscles contracting because they don't want to let the shoulder roll forward. And that's a positive test. That's the positive anterior apprehension test, which is for anterior instability of the shoulder. I then look at inferior instability, and what I do is put my hand on the scapula and lift the arm up, and you can get an inferior apprehension test at this point here. They won't like that and they'll recoil from it. So that's anterior, inferior, and now posterior. The screening test I use for that is the posterior stress test. So the arm internally rotated, straight forward, and then pushing up towards the ceiling. What that does is load the humeral head posteriorly on the socket of the shoulder, the glenoid, and you're looking for pain there. That'll be, in someone with posterior instability, that's typically quite uncomfortable. Looking at instability, you always want to know about ligaments laxity, and so simple tests to look at for that for stretchy ligaments. Violet, can you push your thumb down towards your wrist? Someone who's very lax will be able to get their thumb right up onto the undersurface of their wrist. The next one is middle finger back, so wrist back, finger back, and someone who's really flexible will be able to get their finger parallel to their forearm. The next one is to look at the elbows and see if they hyperextend. So go past, so these actually, Violet's arms do hyperextend a bit. And then shoulder hyperlaxity. What we're looking for with shoulder hyperlaxity is, does external rotation go to 90 degrees? Violet doesn't quite get to 90 degrees, so that doesn't count. And the next thing is hyperabduction, so Gage's test. Hold the scapula down and then push the arm up. And what we're looking for is whether we can get past 120 degrees of abduction. The two tests, external rotation out past 90 degrees and hyperabduction past 120 degrees, equal shoulder hyperlaxity, which is a risk factor for shoulder instability. So that's a rundown on the basic shoulder examination of the shoulder.